Welcome to the Women in Public Policy Program's Seminar Series podcast at the Harvard Kennedy School.
All right, I'm going to go ahead and get us started. Welcome to the Women in Public Policy Seminar. I'm Hannah Riley-Bowles. I'm the Research Director here at WAP, where we are committed to closing gender gaps in the areas of economic opportunity, political participation, health, and education. We are ambitious. Yes. Part of that, contributing to our mission, are these seminar conversations that we have, because it gives us an opportunity to connect researchers with staff and students and fellow faculty to talk about what are the cutting edge, what are the most kind of important ideas that are out there right now about how do we close these gaps. So I'm delighted you could all be here. And for those of you who are sitting in the seminar, what you don't realize is that you're actually part of a much larger virtual community. So we have a very popular podcast now. So you can think of yourself sitting in literally a world community. Now, as we sit in our world community of all these other listeners, we want to be attentive we want to make ourselves as clear as possible. So if you have a question for the speaker, please make sure it's actually a question and that it's got to do with the specifics of the presentation. So we're going to try to keep on track, particularly to keep focus for our virtual listeners. And also related, we would ask that cell phones are turned off. So now I get to do the fun part of introducing our current speaker. Our current speaker is Lisa Berkman. She is the Thomas D. Cabot Professor of Public Policy and Epidemiology. She is also the director of the Harvard Center for Population and Development Studies at the Harvard T.H. Chan School of Public Health. Professor Berkman is a social epidemiologist. What she basically looks at are how indicators of socioeconomic status, gender, and race end up influencing long-term health outcomes. And she's also very concerned with the effects of public policy on bridging gaps across socioeconomic and demographic categories in terms of health outcomes. So I will leave it there. We're very excited for her to present her research today on the long-run impact of maternity leave policies on women's health. Please join me in welcoming.
Great. Well, it's wonderful to be here, and I apologize for being late. I actually had thought there was like an early lunch, and then people started speaking. I didn't realize I was starting off late already. But it's really wonderful to be here. I actually increasingly have come to be engaged with people in public policy, and so having your thoughts about how to frame things and your reactions is really valuable. I'm going to talk today actually about this paper on the long-run effects of maternity leave on women's mental health, but I also have another paper that I thought would give you a very good balance of where this issue is sitting in terms of women and work and stress and long-run health outcomes. So the maternity one is using an experiment as an evaluation, sort of a natural experiment study. The other one is an observational study that I'll get into. But before that, what I want to do is take a few minutes to frame my perspective on why I think this is so important, because it's not the usual frame. I think many of you come from a frame where policy is important in terms of its immediate goal. So maternity benefits are important because they give benefits, actually keep people in the labor force and potentially have effects on children's health. But we don't often think about the long-run health impacts of social and economic policies. Often we think about health care studies as having the most predominant impacts on health. Well, I think that health care is really important. I'm all for it, but it has a negligible impact on health. And if we think about the long-run determinants of health, social and economic policies are far more, have far more potential in terms of really impacting health than anything we do at healthcare at the margins once people are sick. So once we're sick, it's really great. We should all get health care. We should get the best health care. It should be available to everybody. I'm all for it. But it doesn't influence our risk of getting sick in the first place, except a very little primary prevention, which is at the margin of almost all healthcare things. So this is much more promising. So the reason I got here was that I was on a National Academy of Medicine and a National Academy of Science general committee where we were trying to look at the diverging trends in life expectancy for women that had happened in the United States. And this is the first graph that actually frames this National Academy of Science report. And what you see is that in the mid-1980s, and if you backed it up to like 1940s or 50s, you would see that the United States ranked about in the middle in terms of life expectancy among kind of rich industrialized countries. So we never did great, we were never at the top, but we were like hanging in there in the middle. And over the last really 30 years, 25 by this thing, something dramatic pretty much happened, and we have a very poor understanding of what that is. So the United States, if you look at women's life expectancy, it actually increased a tiny bit. So if you look at it and disregard the data from all the other countries, you think, okay, well, we had a little increase in life expectancy, although basically there was a lot of stagnation at later years. But all other countries zoomed ahead, and we are now on the bottom. We rank at the bottom of OECD countries for life expectancy for women. We are the worst, absolute worst for this. And men do only marginally better. When men like have a little bit higher increase in life expectancy and still do poorly, but they don't do as badly as women. Women actually do worse. So there was an Academy report to look at this. I was on it. I would say we looked at all the usual suspects. It accounted for almost none of the variance. This remains a pretty unexplained phenomena. Yep.
So does that mean you didn't look at like socioeconomic, the divergence of socio? You did. Can you talk
did.
about some of the things that you did?
Yeah. So the report has a chapter on smoking, which actually is the one thing that does account for some of this. We looked at inequality. I did a whole chapter on social networks. We did obesity. We looked at medical care. What else did we look at? Pretty much everything you could think of. We looked at hormone status and menopausal kinds of issues, hormone replacement, and none of them, all of them are really important risk factors. They're all really important, but none of them account for the lag, for the difference. That is, inequality didn't rise that much more in the United States compared to a lot of other countries, enough to account for this. And one of the things about the United States in terms of inequality is that while the risk of inequality is pretty high, and certainly in terms of economic inequality, I'll show you, you all know, things have happened. But for instance, education, which was the common denominator, the United States ranks high on, percentage of people finishing high school. So none of these things answered it. Now, the data in some cases were lousy, like to do a comparative cross-country thing with 22 countries, is the lowest common denominator, and often there weren't good data. But it was pretty frustrating. I would say it was not really satisfying. And then I'll show you. And then I want to add to this something that just came out. So Brookings did a report recently on inequality and mostly in relationship to what was happening for Social Security. And there have been a lot of reports of rising inequality and life expectancy, and there have been, you may be familiar with some of the actually very, very intriguing data looking at women who have very low levels of education having absolute increases in mortality. So not only do they not get better a little bit, they actually got absolutely worse. There are a lot of questions about selection in those papers. People have debated it a lot. But this report came out a couple of weeks ago, actually, and I thought it's really beautiful. It's a beautiful, beautiful report, I think, in which they looked at income distributions by deciles. So they spread people along income deciles, looking at different birth cohorts to see what happened in terms of increases in life expectancy for women once they were adults. They actually have men and women in this too. I'll show you both. And what they found was something that also is pretty staggering. So if you look at women at the bottom, these are two cohorts, a cohort of women born in 1920 and 1940. They actually did a whole set of cohort effects, but these illustrate the case. There is really no increase in life expectancy for women in the bottom decile over this time, and almost no increase in the next decile, and a tiny amount here. When you look out at women in the top deciles, there actually are years of increases in life expectancy, like somewhere between 4 and 5 as you're looking at this. So things did get better for women in the top deciles, but complete, like limited improvement or stagnation at the bottom. If you look at men, you see the same, effect in terms of at the top there was actually an absolute increase of 6.4 years. At the bottom there was an increase of 1.8 years in life expectancy for men. It takes you somewhere between 30 and 40% of the women's deciles of women, like 40% of women to get a 1.8 year increase in life expectancy. That's like, the bottom third of the United States, of women in the United States, to get up to what men did at the very bottom.
And is this all US data?
Yes, this is actually, they did two things. One of it is from just looking at SIP data. They did another thing looking at Social Security data, and they did another from the Health and Retirement Survey. And the report is great. If anybody wants to look at the report, it's great, because the implications for extending Social Security benefits and working, or limiting Social Security, having people work longer, what they conclude is that it benefits wealthy people enormously, and it actually disadvantages people at the bottom in a pretty major way. The implications are that extensions of years of working for Social Security, which is something that I actually think is a good idea on the whole, will disadvantage people who are most disadvantaged. So I want you to keep in mind now, okay, the picture is US is on the bottom, and people at the bottom are really at the bottom of the US over this time, and what is going on, right? So here are some other things that are going along that nobody looked at in this National Academy of Science panel, including me. It wasn't until the end of it that I looked and said, we're not dealing with the major phenomena that are happening in America during this time. We're just like looking at the usual suspects in public health. We're looking at smoking, obesity, things that we know are social risk factors, but we're not understanding fundamentally what's happened in the United States that could affect women a lot, men also, but less. That's changed in 25 years. But that was, to me, the question. Well, here are some things that have changed. The number of births to single mothers has escalated hugely in the United States. Here, if we look at share of unmarried women, share of births to unmarried women, it's up around 41%. In 1960, like the way many of these reports are framed, when Moynihan wrote reports that we have a problem, it was 5 or 6%. During this time, we're way up there. And the number of women in the labor force is huge, right? So number of women working with young children is huge. And of course, this is probably the thing that you know the best. If you look at where the United States ranks in paid leave, in the United States, it's here, and it still doesn't have paid leave. It has, FMLA, which applies to about half of workers, and is still an unpaid leave to do it. So we are a country in which actually fertility has remained relatively high. Women have entered the labor force in droves. Most married couples are dual career working, and we have no basically parental leave or maternity leave, even if you look back early. So it's like this perfect storm. It was like this light bulb went up, and I thought, well, this is the hard part of being a working woman in America, especially if you have family obligations. And almost every other country doesn't quite have the perfect storm. So, fertility is high in France. Women are in the labor force in France, but huge social protection, right? In Italy or Spain, fertility has dropped. Japan, fertility has dropped, and women are in the workforce. So almost nobody has this, kind of regular fertility. It's dropped a little bit, but not huge, and participation in the labor force, and no policy. So that's actually what drove a lot of the work that I've done over the last 5 years. And I think this is a completely unproven factor that could account for why women are doing so badly, but it's potentially very revealing. And I think there's like a there to it. So I'm going to show you two studies that suggest that these things are important. and then we can just open it up for discussion. So the first one is on the long-run effects of maternity leave on women's mental health. So just to frame this again, depression is one of the major causes of global burden of disease. It's very important, and almost all maternity studies have looked at the effects of maternity benefits on kids, but not on women who are doing it. And they look at it, if they look at women, they're looking at short-term labor supply, like did it keep women in the labor force, which is actually quite important. So this is just really recapping that when we think about it, there's an increased labor force participation for women during the second half of the 20th century. You can see even in Europe, the percentage of people in the labor force went from about women in the labor force went from about 38% to 71% with at least a child younger than 6. And starting in the early 1960s, many European countries enacted comprehensive maternity leave policies. And at the same time, there's an increasing burden of depression in old age. It's one of the leading cause of disability worldwide, and depressive symptoms are very common in old ages. And our idea has been, if any of you have looked at life course issues, there's a lot of work on early childhood effects on old age or aging consequences. And I think early childhood is a very important time, but I do actually think there are other important times in life. There is adult development at about the time that people finish high school and join the workforce and do family formation. It's another incredibly important element. So our hope was to look at midlife, early adulthood to midlife factors, and how they could actually cause scarring kind of 30 or 40 years later. So our question is, do maternity leave policies affect mental health? And here are some of the ideas that we have for potential pathways. We've done some work on this, but not a lot. But part of the idea is that the channels would be that maternity leave policies could reduce immediate pressures and reduce depression postpartum. Not necessarily postpartum depression is a quite medical term for very severe depression, but women are more likely to be hospitalized for depression around the time they have a child than any other time in their lives. So this is not a small issue. There are stressful life events that are related to recurrent depression, and what we do know is that depression often sets in for everybody in people's early 20s. Very few cases of depression pop up when somebody's 65 de novo. Mostly depression is something that kind of emerges in early adulthood and kind of cycles through people's lives. Yep.
Can I ask a question related to your focus on depression? Are people dying more or less of the same things in the United States as they do? I mean, there's probably like differences in the way things are diagnosed over the course of 25 years, so that would kind of confound things a little bit. But generally, are we dying of the same thing? And then are you sort of presuming that depression just sort of like lowers immune system and resilience, and so that would explain why we're more vulnerable to disease?
So both of those things, but those are really great questions. So it is really hard to look at the causes. In general, the causes of death for poor people are about the same as the causes of death for better off people, but the rates are higher, right?
Okay.
The first cause is heart disease, second is cancer, and that kind of thing. However, if you've read the paper that Ann Case and Angus Deaton wrote on mortality among kind of middle-aged people, they've just wrote a paper, which actually other people have been looking at, but I think what they pointed is that one of the things that's been on the rise and is a larger cause of death than it was before are a whole set of things that are related to mental health. So suicide, opioid use, accidents, things like that. So there is some feeling that mental health issues or violence are like on the rise in certain groups, and I would say it's like a hint, like not a slam dunk, but a hint that this could be. And there are a lot of data that show that depression and the social experiences, the stressful experiences that kind of travel with depression are related to increased mortality risk. So this is a viable mechanism. In fact, the data that I'm going to show you are on SHARE, on the European study of SHARE, and they don't have mortality data, so we couldn't We couldn't look at the mortality data, which I'll show you quickly in a second study. So this is the data that we use. It comes from the Health and Retirement Study in Europe, which is a study of about 19 countries. Over time, we actually look at 13 countries and then limited it more, but it's a multidisciplinary cross-country panel survey that's representative of men and women 50 and over. There are about 30,000 people in this study. We look at a wave 3 study that they did, which they call Share Life, which is an event history, where they actually ask for every year of your life kind of what happened in terms of occupation, family, residential history, stressful life events, health. So we can construct complete working histories for women and complete fertility histories for people. And we look at a mental health outcome from the EuroD, which is a depressive symptom scale in 2004, 2006 when they enrolled a new cohort, and we have an extensive set of measures of control variables, basically physical health, a lot of demographics, labor market behaviors, pensions. The policy data come from Anne Gauthier, who constructed what my understanding is probably the best data on family policy, looking at maternal, parental, and child care leave policies and cash benefits between about 1960 and we go up to 2010 in this. And it covers all the share countries that we wanted to look. Now, we only looked at maternity leave because paternity and family leave is actually quite hard to categorize in this database. And we're looking at women who are older and share life now, so that if we wanted to look at the policies that people were looking at in basically like 1960, 70, 80, it's only maternity policies that are consistent and for which we have enough strength. So it would be great to look at the other policies, but we are just limited in that way. So we only look at maternity leave, and we know from other studies that these policies influence a wide range of labor market outcomes, in fact helping women to kind of remain attached to the labor force. And there have been some maternal studies looking immediately and child health outcomes that are pretty clear. And from this database, we construct a variable that we look at the combination of both cash benefits and time off. It's sort of a generosity measure that contains both the total number of weeks of maternity leave and the cash benefits paid during maternity leave. So it's full wage weeks that you have off. Almost all of the countries that we looked at came very, very close to 100% of replacement if they were doing, if they were paying for that. So that's the way we're looking at this. Most leaves were between, there's a set of countries that have consistently sort of 6 to 12 weeks of leave, and another set 12 to 18 weeks of leave, and Sweden is off the charts. I'll show you the data. We actually in the end exclude Sweden, although it doesn't make a huge difference. It's just during that time Sweden went to about a year of leave. So we look, we use these full wage weeks as basically our exposure. And this is what the data look like. These are all the countries that we have good data for. This is Sweden. Up here, it's paid maternity leave over the years between 1960 and 2010. And in this slide, just Sweden dominates, so you can't actually see the variation. So if we just take Sweden out, you see, because we're going to do country fixed effects, that if we do country fixed effects, we still have like a lot of variation to be looking at over time. In terms of who we're looking at, we actually have done a lot of kind of identification and trying different groups. In the end, we looked at first childbirths because we thought that people could select differentially if we looked at all childbirths. People might decide in generous states, countries, they might have more kids. So we wanted to do that. And in the end, we actually reduced the age to between 16 and 25, also in part to be ultra conservative about when women were calculating, with the idea that women were most likely to not be influenced by the policy if they had early births, and it actually allowed us to compare it to women who were not working. Really, so it was just a reduced possibility to adjust labor market involvement And we actually have done it other ways as well. It doesn't make a huge difference.
Yeah, could you just share, do you have a sense of what percentage of first births fall into the 16
Oh
to
gosh,
25
I bet
range?
it's in the paper. I want to say that it's a lot for this age. I mean, like I would have said 30 or 40%. We did also an analysis. The number that I do remember is that we thought about looking at women who only had one kid, but that's a tiny percent of the group of women who had kids. It's like 7%. So a lot of women do this. This is like before women were 35 when they had kids, by and large.
Did you
Yeah.
also do a sensitivity analysis to check if that
Yes.
differed?
Yes. So we've done a lot of sensitivity analyses. A lot of it are in the paper. We looked at women of a much broader age range. As a matter of fact, we didn't do this till reviewers kind of pushed back. I don't think there's a huge amount, except reviewers just were so concerned with selection that they kept pushing and pushing. So that's what we have. But if you looked at 16 to 30, it doesn't turn out very differently. And in fact, if you look at all childbirths, it doesn't turn out actually to be that differently. So we've done a bunch of sensitivity analysis. So we're going to do country fixed effects as well as year of birth fixed effects. And we also control for age, education, marital status, total fertility, physical health at old age, health behaviors, birth control, and country-specific year of birth trends over time. And if we just look at the difference in depression score by full wage weeks among not working women who had a childbirth at the same time, actually, so they're matched by year for when they had a kid, and working women, and you look at, these are the full wage weeks at the bottom, you see at the very beginning, actually, working at childbirth has slightly higher depression scores, lower, but as soon as these benefits kick in, you see that women who are not working at childbirth actually have higher depression scores than women who are working, matching on childbirth. So this is just a very descriptive kind of thing. Obviously related, potentially, a lot of selection could go in here. And just to look at this differential, by taking the difference in that former graph, you see here's the little space where non-working women actually are doing better than working women, and then you see as full wage weeks kick in, this really quite powerful effect on depressive symptoms. And ultimately, this is the difference in difference score. So we compare working women who are either in countries with maternity leave benefits that are low or high, and these are their depressive symptom scores, or women who are not working, had a child in the same period, the same age, who are also living in countries where the maternity leave benefits are low or high, and then we do a difference in difference, and basically the 16% out there is the difference in depression scores between living in a low versus a high country-specific, or it's the difference between the benefit of living in a high full wage week country having a child, when you look at the difference between working and non-working women. Now, one of the things about this is that we've been questioned about this as a control group. We did this because we assumed that women who are not working shouldn't benefit from the maternity benefits, right? And I still think this is a really good control group. People have asked, well, what about men? Like, just in terms of what was going on, because a lot of policies kicked in during the same period that maternity benefits kicked in. Unemployment kicked in, pensions kicked in. So a lot of our work has been to isolate the effect of maternity benefits. And we thought ultimately this is the best comparison of just looking at women who are not working. But if you look at men, you see the same actually as the control group. You see the same kind of thing. And we actually, in lots of the models and when we're looking at sensitivity analysis, we actually tried to construct a variable of unintended pregnancies, which was whether you lived in a country with no abortion or anti-abortion laws, or pills weren't available early on, birth control was limited and things like that. And all of these basically stand up. I mean, it's incredibly robust. Almost any cluster of variables that you can say, well, I wonder whether this is true or not, it looks like this holds up at about the same magnitude. Yep.
The women who did not have benefits, did they in fact go back to work way sooner than the women who had benefits?
That's a really good question. You
Because
know
I think
what?
there is American data showing this.
Actually, that's a really good question, and I don't remember. I don't remember what happened.
Yeah, and-
But we could look at that because we've got these life histories.
Yeah. I
That's a
think-
great question.
Yeah, and my other thought is, how much is sleep a mediating factor here?
Yes. You
Because
must
when
be
you
a
know-
mother and a working mother.
And a grandmother.
Yes.
Right.
So sleep is one of the, totally hot hypotheses. And actually I didn't bring the slide that I was going to bring about our other work-family study. Sleep is incredibly reactive to work-family strain in lots of ways. And we have actigraphy data for this other study that I'm going to show you that shows that sleep is probably one of the really important mechanisms. And our intervention that I will also show you, and also you're going to have Erin Kelly come next week. Erin and I worked together on the same work-family project for many years, so I think she'll fill you in a lot on that study, and she'll probably show you, I hope, some of the sleep data, or I'll email her to show some of the sleep data. So the idea is that sleep actually biologically influences your risk of depression, as well as a whole set of health and metabolic variables. So in these data, we don't have sleep.
Even lifespan.
Yes, yes. Sleep is really important, and I actually resisted when I first started these actigraphy studies. People, I said, no, it's depression that influences sleep, which it does. When you're really depressed, it actually disrupts your sleep cycle as well. So it goes that direction. But sleep also causes incredible changes.
And can in fact, if you sleep deprived people, they will become depressed.
Yes, right. So I think that that's a really good mechanism potentially. Yeah.
It's terrible news, but.
Sorry.
When I'm looking at this, there's almost a bigger gap, isn't there, for the non-working
Yeah,
than
so-
the working? So how do you think about that? I mean, that's driving part of the difference in difference,
Yes,
right?
yes.
Yeah.
Actually, this is the mystery, right? Like, why do not working women in high maternity leave countries have higher depression rates? And we actually don't totally understand that, but one of the things is that it may be a comparative sort of thing. Like, if you live in a high benefit country, and in fact you've made this choice somehow, like you're not in the labor force when actually the majority of people are in the majority of women are in the labor force, it may be that it is really depressing. So yeah, part of what drives this is this difference, which we don't totally have a handle on, but it's notable. Yeah.
And I think that in addition to there being the effect of after the decision is made,
Yeah.
that there may be this experience of being outside the norm group, but I also think it's who
Mhm.
selects in. That it may be that people who have whatever they are, physical, mental,
Mhm.
or other issues, which make it harder to do both roles.
Mm-hmm.
So I think that you also are seeing a selection bias.
Yeah. I mean, there are selection things that still potentially enter in here, except that it's like this difference to do it. But it is like intriguing that group is worse off, whether they select out in a country where they could have had maternity leaves and they have kids, or whether something else happens. It's really mysterious. And then we'll go around. Go ahead.
In that number set, did you also have a sense of socioeconomic option and viability?
You mean?
Meaning, was the set, when we look at the not working in high benefit countries,
Right.
are the people who are home depressed and not working less likely to have had access to education, access to the labor market? So are you really seeing?
Yeah, so
in
we
essence, the
control
effects of
for
your-
all of those things. We're controlling for anything that we have about their income or their work status or their history during that period. One of the things we don't know, remember, this is depression when they're in the older ages, right? This is not their depression at the time that they were in the workforce, because we don't have that. We have it when they were older. And we're assuming, we're thinking, well, one channel might be this sort of thing. So we control as best we can for what the environment was then, but we're limited. We're limited in what we have. Yep.
I think you just answered my question.
Yep.
The time frame. What's the time frame? 20 weeks.
The time frame.
Of this study. How?
So the study. So the people had to be 50 and over. like in 2004. So think of them as in a cohort that was, I mean, they tend to be like a 1940 cohort or above. I mean, there are some people born who would be a 1930s cohort. A lot of people are in 1940s and 1950s cohorts. So they would have been working, figure like, we look from 1960 to 1980s, 90s, that's when most of their births were.
Right, thank you.
And I know that you accounted for SES, but how did your estimates look when, for your working people, you had the lower types of job types and
Uh-huh.
the higher types? How much difference?
So we didn't actually, we were at the limit of anything we could do other than control for these things. Like, we tried to actually stratify by a bunch of things. Gets to be really hard. So we have all that data in there, and it may be that the best thing is for me to go on to the next study, because
Yeah.
all these things actually relate to the next study in terms of observational stuff, and I can show you like a little bit better how it works, how it plays out observationally at least.
Hopefully, quick question.
Mhm.
Did you also look at the cohort of women who didn't have children?
They're excluded from this, but in other analyses we have actually looked
And
at
where
them.
do they fall on the depression scale?
They're not in here.
But if you were to take their depression score at age 50 and above, who do they look more like?
What do they look like? Women who were not working or not working?
I guess either.
So I think what happens is that they look a little bit more like not working people, but we took them out pretty early. So we basically looked at people who had a first birth. That was the study. But that's also a good point. I mean, we can go back and look at a bunch of these. Okay, so tell me about timing.
So we've gotten to the top of the hour.
Okay, so let me go to the second study, and I will go through it so that you get sort of the gestalt of it, and then we can come back and talk about what we think. So overall, just to conclude this, depression in old age is linked to maternity leave policies during the critical period of a birth of a first child, and there's about a 16% advantage by living in a country with high maternity leave policies. We think that there are a couple of mechanisms. One is that it actually reduces stress and depression, which is ultimately linked to recurrent depression during that time. And we have some data on that, because we have some data on life events in midlife, and it looks like that's happening. But we also think it could have helped you bond with your child better. It could have set up, a long-run labor force participation attachment that continues to play out, and that reduces stress over your entire life cycle, so that this event that's kind of acute event actually is not really an acute event. It kind of enables people to stay in the workforce, it helps them to bond and establish a good relationship with children, and then move on. But again, very limited data. The other thing I just want to point out, especially for policy people, is that depression is very costly. People who are depressed use more health services, more medical supplies, more home care, assisted living than older people without depression. And there have been some calculations of the mean direct healthcare costs in old age per patient. And here they are. It's about 5,241 euros for people who are depressed, compared to 3,648 per year for non-depressed. So it's about a 30% difference. It's huge. It's actually a huge difference. And a lot of the cost-benefit analyses that anybody does about policies ignore long-run health effects. They almost never have them. They have short-run effects. They have labor supply things. They have things that you can attach a dollar amount to pretty easily. But if you started to think about the range of policies that have long-run health impacts, and feed that into a cost-benefit analysis, it would probably help a lot of social and economic policies in making the case. So we do that, and in fact, there are some countries, including the Czech Republic, the Netherlands, Ireland, Lithuania, that have implemented cuts to current benefit provisions, in part on cost-benefit sorts of arguments, when in fact nobody has counted these kind of costs in. So that's the other argument. So let me go to a kind of a sister study that we launched with this. We've done a whole series of papers, but this is the last one that actually includes a measure of job strain in it. And it's about what happens when you have this combination of work stress, motherhood, and whether you're single or married, in terms of predicting mortality risk for women. Many existing approaches to this look at a single exposure time point and a longitudinal outcome, right? Almost nobody thinks, well, nobody's work-family life is actually constant. It's a completely variable thing. But we often, because it's really hard statistically to think about doing this, like take one slice. Well, what were you doing at 35? What were you doing at 30? What were you doing at 40 or something? So clearly work-family situations are not constant. So we tried to come to grips with this. And I'll show you how we did it. We did this in women who are in the health and retirement study, which is the sister study to SHARE. In the United States, women born between 1935 and 56, which is very parallel to the analyses I just showed you. There were about 7,500. And again, we could have complete histories, not quite as good as SHARE. HRS actually didn't do quite as well as SHARE in terms of doing a year-by-year analysis. And we needed some imputations here. But we did basically have, for each age, between 16 and 50, we asked, was the woman married? HRS, again, did this great job at not asking partnership status until recently. So when you go back, they just asked whether you were married or not. So we have no data on partnerships in this, which is really too bad because all the European countries have data on partnership status, but we don't. We asked whether they had a child under 18 and were they working. So it's 3 combinations. So there are 8 possible combinations each year. Okay, so you can kind of see where we're going. We actually reduced it to kind of 6 kind of common streams because there were some categories that had very, very few people in them. However, what I want to say is that this is an impossible task to do perfectly. That there's enormous heterogeneity in all these combinations. In fact, theoretically, there's like 4 times 10 to the 31 ways women could combine marriage, work, and children. And in fact, when you look at the data, this is not for you to really look. If you just want to see how many unique combinations, of the 7,536 women, there were 6,489 unique combinations. So that's an impossible thing to look at. So what we've done is a sequence analysis, which is actually a little bit like a genetic sequence analysis, where you look at, and it's very similar to a kind of cluster, where you identify common patterns. Statistically, empirically, you identify common patterns. And cluster people who are similar but not identical, right? Because otherwise there are 6,000 of them. And these were the groups that we defined when we did the sequence analysis that seemed to describe most people pretty well. So if you looked at the bottom, 34% of people fall into the category, this is 16, that's when they're 50. So the pink is not working and not having kids, right? So their early years, they're not working, not having kids. Then they move to the purple, they're working, they still don't have kids. They're green, they are working, they're married, and they have kids. And then, somewhere around 48, which probably sounds right for us, finally, like, kids leave, and they don't have kids at home, and they're back to working with no kids. But if you look at the patterns, you can see there's a huge diversity. So this pattern is not working and not having kids early on, and then there's no work, no marriage, but they do have kids. So these are like non-working single mothers. And then they go back. This one, for instance, is not working, no kids early on, and then they move into a category where they work and have kids, but they're single. That's 8%. So you can see these various combinations, and they describe imperfectly the range of options. And if we just look at their mortality rates, their age-standardized mortality rates, you can see, without controlling for anything for a minute, you can see what happens. So married mothers do the best. And working earlier or later is the best. So the best option, you'll be all happy, is to be a working married mom in this. Now, there are clearly selection factors going on, right? We know through all of this there's selection. That's why I started with the maternity benefits. These are the women who are healthiest. And the best option actually seems empirically that it's people who took off a little time. Either they took off a little time early in their careers or they took off a little time later in their careers. They didn't totally work straight through. Then these are working non-moms. So these are women who are working who never had children. They have pretty low mortality rates. These are married mothers who didn't have children who always, these are married moms who always work. That is, they didn't take off any time, right, compared to these, and they have slightly higher mortalities. And then married mothers who never worked actually have high mortality. Now there is undoubtedly selection in this if people stayed at home, but it also is kind of intriguing that there isn't a huge protective effect to staying at home and not working as a married mom. And down here you have single mothers. And whether they're working or non-working, single non-working mothers are clearly, there's a selection thing that goes on and they're at huge risk. But single working moms are at risk, and I would say of all the studies we've done, we've seen the penalty, actually, the long-term disadvantage that single mothers have in this, even when they're partnered. So in the European data, we can actually look at this. It still seems like it's really hard, but it's really hard in the United States. And in the United States, it's in part mediated by poverty. So the fact that working single moms are so poor actually accounts for a bunch of it, but you can see it in other countries too. So I don't want you to hang on to this a lot because it's not controlling for things. I just wanted you to kind of see how this plays out. Now, one of the things that we've speculated is that people who are in jobs where they have high control and low demand would be very protective in this. And we actually speculated that this would be especially true for single mothers. I'm going to tell you the bottom line is it doesn't actually protect particularly against single mothers. But workplace schedule control and those sorts of control policies should be kind of symbolic of workplace flexibility, and we think are important. So in order to do that, we actually looked at occupation and industry measured census codes which have been walked back to 1970 when most of these women were in the workforce. And then we used, there's some very good work in Europe looking at average demand control, job strain measures for demand and control. And this has been crosswalked between Europe and the United States to match to occupation. So we actually basically assigned a job that a woman was in, a job strain score based on their occupation. Not what they reported, but on the occupation. So if any of you are you familiar with these job strain things? So, you know, like an example of a low demand, low control job is like a doorman. Like there are some jobs where you have to sit there the whole time and you have no control, but you also have no demand. That turns out to be not terrific. But to be in a fast-paced, like if you're a factory worker, this is where this evolved, and you're in a high demand, that is you have to keep making widgets, right? And you have no control over pacing, that's a really high stress job. So we basically looked at this, and in the end, each person had a family trajectory, a job control tertile, and a job demand tertile. And then we looked at the association between these three things together to see what their mortality risk was. And basically, this is actually not such an easy thing to look at. If you looked at later single mothers, earlier single mothers, I hope I didn't actually put the wrong, there it is, that's the one I want. So this is combining everything together. So if you were like the average married mother and you were in a high control job, you're the reference. That's the best possible life, all right? And you can still see there's some increase in risk if you're in a low control job. If you were a single mother here, whether you were a single mother early in your life or later in your life, low job control is really increasing your JIP. So if you're a single mom and basically you are in a low control job, you have a really increased risk compared to this person. But single moms always have increased risks, no matter what their job is. Even, here, high control job, you see the increased risk. And you see actually for basically married moms who are in the workforce that having a low control job also is somewhat elevated, but it's not as high as this. Like this is the most toxic combination out there. Now we've looked at economic status, which plays a lot into this. And one of the issues is economic status always is a really important predictor of this. It's like in there a lot. Low control jobs are highly correlated with economic conditions, really highly correlated, like 0.5 or something like that with this. In fact, people have argued that the definition of control is synonymous with having a low-income job for doing it. So it's hard to separate that out, but I don't want to say that this eradicates the effect of low-income working wage jobs, because it doesn't. It's just almost saying the same thing to this. So these are observational data, and they also suggest that this combination of working and having a high-stress job together are really tough, but they're particularly tough for women who are not married, who are single in these data. So that really is it. So public policies related to maternity leave can have these long-run effects at older ages, that appear in older ages. And work-family conflict can have really a profound impact on health, especially among, I would say, people with limited resources, whether they're social or economic. So I think that's why single moms come out particularly, and also while lower wage workers also come out as being particularly vulnerable in this. So
Wonderful, that was terrific. I've got questions. Can I just ask a clarifying question while other people put together their thoughts? So you don't have socioeconomic control data then in this one that you just showed us?
Not in the very last model, but in all the other models.
In all the other models you did?
Yes.
Okay. But so the share also had the benefit of
the
having...
share totally
had it, but this other one that's conducted in the U.S. doesn't give you the socioeconomic breakdown.
It does. It doesn't have income for those areas, but it has occupation, which we can code into categories. But because the job strain categories are coded by occupational code,
There's a confound.
they're the same. They're in this case the same thing. So it's really hard to look at them separately. We've actually looked at it with fewer digits, looking at more general occupations, and you can see it. But it's because they're both basically measured by occupational codes,
Right.
Not income. Right?
So if you go back to the one that you showed, the first one, the where you had I think late break or early break, and then you had, have you looked at occupational differences within groups, just even simple differences?
No, it would be actually a really good idea.
Because one thing I was thinking is the continuum. I don't
great,
know, but presumably you have to have pretty high SES to have that choice to have taken a break earlier and later in life. And so I was just thinking that maybe that's the most interesting comparison between the not working, right? Because probably demographically there is this, you know what I mean, if you wanted to go back and look at choice.
Really good idea.
Because it really, in your first study, you don't emphasize it much in your conclusions, but there really is this almost being a mother who doesn't work in a society when women have that option. And
that's
and
sort
it's
of two little pieces.
In both of them, it seems this really thing, and it's like a deflation of status.
Yeah.
Which is a very, it's really kind of profound.
Actually, I've never thought, you're right, it's in both studies.
It's in both studies,
to do it, okay, yeah. Yeah, non-working women don't come out well, whether it's selection or something.
Yeah.
They don't fare well.
Right.
Yes.
Have you given any thought to the availability and cost of childcare as it feeds into this?
Yes, we don't have any good comparative data.
Mm.
We have thought about it a lot. As a matter of fact, we've tried to think of other policies that we could use to illustrate it besides maternity benefits, and childcare is number one on the list. And the comparative data are terrible.
Yeah.
And the kind of the policy is really hard as well. So we can see whether individuals do it, but it's really hard.
Because
But it would be great.
Yeah, it strikes me that some women may feel a forced choice.
Mhm.
That essentially, maybe not just with one child, but by the time they have the second child,
Mhm.
to pay for those 2 kids, they essentially don't make enough to
Yeah.
justify doing that.
Yeah, yeah, it would be great. We could certainly look
And
at that.
then their identity, they
Yeah.
lose their whole
Yeah.
work identity, and by the time they get back, they've lost years of
Yes.
possible career advancement that they can never get back.
Right, right. That's really interesting. And we could look at that. We just can't quite look at it with as
Right.
good a policy kind of instrument as we do
Yeah.
here, but it's a great idea.
I'm gonna have another one.
Or pushback, tell me
Yeah,
you don't
pushback.
believe me. Tell me you think this is nuts. Like, it's not what's wrong with America today. There's something else. I mean, I actually gave a talk last night and, to a Harvard alumni kind of development thing, and they all said, well, we're not gonna change work, it's obesity. It's that everybody can afford to buy terrible food. And I thought, whoa, where did that come from? And I pushed back. But this is not, I think these 2 studies are strong, but I think that in terms of explaining why the US is doing so badly, or what's explaining this mortality stagnation at the bottom, there are a lot of potential explanations. I wouldn't say this is it. I just think it's an incredibly interesting research area and one you should all go into or push back. So skeptics welcome.
Can I ask a question that maybe the students would enter in on, but how is this received when you talk to policymakers? I mean, this is what, it's such, we have this problem in the United States, and the private sector as well as the public sector, of getting people to think in very long-term time horizons. And I'm just wondering what type of responses you get when you engage with policymakers. I mean, are they able to weight in such long-term effects into current decision-making?
So let me say two different things. One is there are people, I actually testified for Bernie Sanders for an inequality thing, years ago, 4 or 5 years ago, before anybody thought he would do what he's doing. And Elizabeth Warren was there as well. They totally got it. And so did the people from Minnesota who were there.
Yeah.
And for people with a liberal agenda kind of see this honestly as fodder, they should be using this as ammunition. They're incredibly pro this kind of thinking. However, the other flip side that's been really interesting, and Erin again will talk more about this next week, in our work-family study we have 2 industries, and the one that I led was in nursing homes, and it was nursing home systems where we basically did. So low-wage, hourly workers in a nursing home, and I thought nursing homes would never let us in and would be completely against us kind of fooling around with workplace flexibility and work-family things. They were ecstatic about it, and it was the top of their agenda because they know that they miss their cost of turnover, where all good people leave. In some nursing homes, nurses, 85% of nurses turn over in a year, or CNAs, but certainly people who are competent keep climbing a ladder and go to a better nursing home and a better benefits and a better place. And sickness absence. So the rule in a nursing home without any policy about anything is that the only alternative you can do is call in sick. And you then have to say you're sick, can't say your kid's sick or your mother's sick, and you basically call out for a day. And in fact, mostly what goes on is probably a lot like our lives, they do have a sick kid, they have to go to the doctor. They have a teacher thing, they have to go to a teacher thing. Their mother is needs a ride home from the doctor. And if you planned it, and could be honest, you would take off 2 hours. You would say, I'm here till 1, I have to go pick up my mom, and I'll be back. Again, but they can't be truthful. So they were completely open to us doing an intervention around work-family things where people could have increased schedule control. And they saw this as good for the bottom line. That's a for-profit where the bottom line is, tiny margin. And so you can see that there are companies out there who can frame this, not so much in terms of the 35-year long run, but that this could be good for their workforce. They know they're losing. They know, especially in industries dominated by women, that they're losing a lot by not having some kind of flexibility. And they're just, I think, really fearful that it will be too expensive, right? They can't all have paid leave for 4 months or something, or 6 months. That's, kind of the Cadillac. But they can do something, and they're pretty open to it. I've been surprised how receptive businesses are to this.
I think we're starting to see that also, because there's some Google, Bill and Melinda Gates, they're starting
Mhm.
to offer maternity leave benefits for women. So,
Yeah.
and there's also a state that's
California has
That's-
paid sick leave,
so-
paid family leave, right?
So when you do this study again some years from now, there
Yeah.
might be some noticeable differences. And I wanted to say that in terms of your conclusions, I absolutely agree with your 2 points. However, I think that from your results, I did personally a study on a global study on mothers, on women in general, and in all countries that we studied, lone mothers fared poorest, and you see also in your
Yes.
results. And so I would, in my view, I think maybe you could add a third bullet point that highlights, especially for lone mothers, we
Yeah.
need to have a special policy
Yeah.
for these women. So
Actually,
it's
that's
not,
really
because
good.
they don't, a lot of them can't access a maternity leave benefit, is
Right.
what you.
Right, I think
shown.
that's excellent, and we have the same thing. Being a lone mother is incredibly related to risk in almost every country we look at. And we've tried it actually in developing countries too. We had a workshop where we had women from India and China, and they all said it's the same issue. Like, the solution is really different, but the issue is really similar. Yeah.
Just a comment, because we're
Yes.
talking about public policy, that it's really good and ideal to have a long maternity leave for mothers, but its effect, for example, in the Philippines, it could discourage employers from employing women, because they would be benefiting women. So
Yeah.
also a cost benefit analysis. I'm just thinking
Yeah.
about that when we write about public policy, how this would impact indirectly.
Yep, yep. I think actually, I think maternity benefits can be expensive, and they're differential, right? So that was one of the things in our nursing home study is, like, we're gonna give people flexibility who have kids, but not who have blah, blah. So, it can be really hard. I would say ultimately, like, family leaves are better and more neutral. I mean, we just couldn't evaluate that here. But policies, like in Finland, where they have these linked family leave policies for both partners, is probably the ideal going forward. But if it keeps people out of the, if it limits women's opportunities to be hired, that's like the negative spillover. That's really, it's tough.
You've left us with a lot to think about. Yeah, thank you very much.
You're welcome.
Next week, as Lisa already mentioned, we've got Erin Kelly coming. She's a professor of work and organization studies at the Institute for Work and Employment Research at MIT Sloan School of Management. She's going to talk about redesigning work, findings from the Work, Family, and Health Network, and implications for gender inequality. So we're really looking forward to that talk. Hope you'll join us for that as well. Thanks again.